This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Well, good afternoon. I'm Brian Anderson. I'm one of the paediatric anaesthetists intensivists at Starship, and it's my absolute pleasure to introduce four of my colleagues this afternoon. So first up is David Buckley, who's going to speak about what's new in paediatric ventilation. Now, David's currently working at the Paediatric Intensive Care, and he's also a cardiac anaesthetist. His work interests are congenital heart disease management, mechanical ventilation, transport medicine. Interests outside of work, and this is probably more important, fishing, hunting, golf, snowboarding, and I should add, alcohol. David, come on up and take the stage. One of the other good thing about having your friends up here is that if they go over time, I can...
Thank you, Brian, for that kind introduction. I don't have any conflicts of interest other than I'm particularly cynical about all new modes of ventilation, but I will mention a few just to keep me honest. So what's new in paediatrics? I was tempted to say not a lot, but I have actually made a talk out of it, and there are quite a few things which I think are quite interesting. This is where I work. We used to think this was pretty flash, but all you Australians have now got flash new hospitals, so we've got a bit of hospital envy going on. You can see that it looks slightly sort of faded or slightly blurry like old people do when they have those photos done to make them look more attractive. But we like our hospital, it's good. And I'll just show this one now because I don't get a chance to show it on Sunday, but looking good, Richie. What I'm mostly going to talk about is not new modes of ventilation in particular, but new ways that we tend to think about ventilation. And a lot of this stuff it's not unique to paediatrics. We're quite lucky in paediatrics because we draw from the neonates and we draw from the adults. We have some things which are sort of our own, but we usually manage to sort of get things from both of those sides and mix it around a bit. So the things I'm going to talk about are ventilator-induced lung injury, about non-invasive respiratory support, because I think in the paediatric and neonatal world that has really taken off in the last little while, driven mainly by changes in technology. A little about high frequency and something about ARDS. A couple of the newer ventilation modes like proportional assist and NAVA, and then a little bit about some of the new equipment that we do have. If you look at why we ventilate patients in the PICU, a lot of those patients do not have respiratory disease. They're ventilated for other reasons, and this is a study looking at a whole lot of PICU patients in Italy, and they've looked at why the reason they got mechanically ventilated, and 20% of them, 25% of them, it was for a respiratory reason. 75% was for some other reason like fits or sepsis or post-operatively. So a lot of the patients that we're ventilating are patients who haven't got a lung problem. So you'd think that we should be able to do that successfully without mucking them up too much. And there has been, yes it is, there's been a lot of thought about in the adult and ARDS about using low volume ventilation to prevent the cause of ventilator-induced lung injury or prevent ventilator-induced lung injury. What they've found, looking at a lot of the anaesthetic stuff these days, is that same risk of damaging the lungs applies if you're ventilating someone with normal lungs. So you shouldn't just be limiting your tidal volume for patients who have lung disease, but you should be limiting your tidal volume for patients who do not have lung disease. And I think we, on the whole, have been pretty poor at that. Like we've got the message about, sick lungs, baby lungs, ventilate them with small tidal volumes. We do tend to over-ventilate or use bigger tidal volumes than we should in patients who have normal lungs. And this is a study that was in critical care medicine, and what they found is that the rate of ventilator-induced lung injury almost went up exponentially as you increase tidal volume. So what we should be doing is backing off our tidal volume even in patients who do not have injured lungs. And I always thought that the paediatric and neonatal lung was far more prone to ventilator-induced lung injury than the adult lung, but this paper that was by Art Slutsky and another guy from Toronto they actually showed that the paediatric lung is more resistant to ventilator-induced lung injury than the adult lung. And that's for a number of reasons. Like the paediatric lung, you ventilate it badly, doesn't produce so much interleukin and tumour necrosis factor. It produces more surfactant than the adult lung. It's more distensible than the adult lung, so it tends not to be damaged so much. Non-invasive ventilation, we always struggled with that in the paediatric world because, you know, you couldn't put a tight-fitting mask on a kid because they wouldn't tolerate it. If the thing had a big leak, it didn't work very well. The triggering was poor. The leak compensation was even worse. And in the last 10 years, the technology for that non-invasive ventilation has improved out of sight. And it's enabled us to deal with a lot of patients now and not invasively ventilate them. Bubble CPAP, like Fisher and Paykel, I'm not, you know, putting an ad in for Fisher and Paykel, but you can buy pre-made kits which have, like for high flow or for bubble CPAP, that have everything you need. They have a headpiece that fits on. They have the, you know, it's all really easy to set up and it works really well. We use a lot of bubble CPAP. The problem with the F&P one, well, with that, the system that we use, is limited to a peak flow of 15 litres per minute, and our standard flow is we do like 2 litres per kilo, 2 litres per minute per kilo. So anyone over about 7 kilos, it's getting to be too small. So then we have to move on to the high flow. But that, you know, that was, bubble CPAP was sort of brought to New Zealand by a guy who came from Columbia and New York. At the time he introduced it here, he was bagged as it, you know, being a bad thing, and we all knew what to do. And it's just, I mean, in the neonatal world, it's revolutionised the care of the baby with ARDS, and for us it's been fantastic. We use a lot of bubble CPAP, and we find that there's either a mask interface or a nasal prong interface, and it's quite well tolerated by babies, so that they don't need to be heavily sedated. It looks like they would, but a lot of babies will tolerate that, because I think because it gives them so much, like it makes their breathing easier, so they tend to just lie there and take it, and we don't have to heavily sedate them. And that's how it works. You know, it's pretty simple, really. You have a water level which determines your level of CPAP, and you have a constant flow that flows past the patient. And as I said, we set it up to do 2 litres per kilo per minute, so much above 7 kilos it runs out of grunt. And then it comes with, as I said, a mask or a nasal prong interface. It has a nice bonnet with a clip system that holds it all in place, and then a water chamber that's easy to fill, and it's all pushed together easily so you can't muck it up when you assemble it. And it's not new technology. This is a paper from the British Journal of Anaesthesia in 1981. They were using bubble CPAP, you know, in bronchiolitis. And it's weird that I think it didn't take off because at the time it was a hassle. You had to sort of make up your own system, whereas now you can buy one off the shelf, assemble it easily, and it works really well. The other thing about non-invasive ventilation, obviously, you know, like, it's not a panacea. We find a lot of patients now will have on non-invasive ventilation to the point, especially if they've got interstitial lung disease, they'll be on 80–90% oxygen, a reasonable amount of CPAP. When you go and intubate and ventilate those patients, often their saturations deteriorate. So they, you know, you can do it to the point of, if you know that they're not going to improve when you start ventilating them, it gets quite difficult to manage them. But we have a lot of, you know, obviously like everyone else, we have a lot of bronchiolitis, and it's really made a huge difference to us dealing with that. And then, you know, humidified high flow nasal cannula. I mean, we're all using that. They use it in the adults a lot. We use it heaps. Again, the technology sort of caught up with it, and it's become so easy to use. That's our sort of go-to treatment for. We used to do the bubble, and then we used to use a short tube CPAP hooked up to a constant flow on a ventilator. Now we just use high flow. If we need more than high flow, we sometimes go with a mask and supply some CPAP, but most bigger kids won't tolerate that very well. So it's mostly high flow. And again, you know, like there's a whole range of purpose-built adapters and connectors, so you can get exactly the right set of nasal prongs that go. They sit really well. They get taped in with the new flow provider. You know that they can get the flow down to 2 litres a minute. So on the older versions, we had to use something else because the flow didn't go low enough. Now the new one goes between 2 and 60 litres a minute, and it's been great. In our hospital, we currently don't do that in the ward, which seems bizarre to me. We will hopefully start introducing it, but a lot of hospitals, a lot of paediatric wards around the country will run high flow in their ward, in the high dependency part of their ward, and that saved us a lot of admissions and transfers over the winter. The problem for us is get those patients, you put them on high flow, they look quite good, and if we go to get them and transport them somewhere, we can't transport them on high flow because we don't have the ability to do that. And so sometimes we end up having to intubate those patients to transport them, which seems counterproductive. When we get them to our hospital, then we have to extubate them and put them back onto high flow again. These are 3 dodgy-looking characters. Like they won the Nobel Peace Prize for discovery of nitric oxide as a signalling molecule, and 2 of them, if you look at their website, if you look them up on the web, they're marketing all these weird products for, you know, like men's health and that sort of thing, based on the ability of nitric oxide to somehow cause something like that. But I mean, we're big nitric oxide users in New Zealand because we buy it from BOC and big cylinders and we pay very little money for it. So for us it's cheap and it's very effective as a pulmonary vasodilator, as a selective pulmonary vasodilator. I know, you know, throughout Australia and the rest of the world, its use is on the wane because of the cost of it. And, you know, a lot of people are looking at using sildenafil or either intravenously or orally as a pulmonary vasodilator, but it doesn't tend to improve your... I mean, it drops your pulmonary pressure, that is true, but it tends not to increase your saturation in the way that nitric oxide does. It's, you know, it's tainted by the fact that, like a lot of things that we do, it's been shown to make no difference to your overall mortality, but in the middle of the night when someone's saturating at 70% or 60%, you put that on, it jumps up to 90, it does make you feel better. It allows you to get some sleep. Yeah, I mean, we don't, I think in Australia, do you guys have intravenous sildenafil in Australia? We don't. We're in the process of trying to get it here. We just have oral sildenafil, so we use a lot of that, and a lot of nitric oxide. The oscillator, you know, the oscillator is a weird thing, I reckon. Like the neonates fell in love with it on pretty skimpy evidence, and we carry that on in paediatrics on even skimpier evidence. The adults, at least, like they gave it a good crack, and they just said, you know, do two big trials, and it's gone. You know, it was going to be the next best thing for them as well. And if you look at controlled trials or meta-analyses of oscillator versus conventional ventilation in paediatric patients, there's very little evidence for it being any benefit, particularly once we started limiting tidal volume and, you know, and being much better with our conventional ventilator. That's not to say we use it a lot. We do use it a lot, and it is useful for controlling the CO2 sometimes, but it's probably, I don't know. I can't make my mind up whether it's a useful thing or not. I mean, we use it, but I don't know if it's good. And those are the sort of, that's the summary of the paediatric experience of it, and you can see that there's none of them have showed any significant difference to oscillation versus conventional ventilation. And they are old trials. They go back to the days where we were flogging the lungs with big tidal volumes. So these days, I'd say that the evidence for oscillation being a useful ventilation technique in paediatrics is very, very low. And even that's one of even the neonatal evidence at the time that it got introduced into neonatal practice was really poor. You know, if you and a lot of I know the adult guys will say, you know, if you ventilate someone well conventionally, then the use of high frequency oscillation should be minimal. And then that's one of the adult trials that showed that it didn't make any difference. ARDS. a lot of the stuff that's come to paediatrics has come via the adults, although there is a paediatric group which has recently, I think in June of this year, came out with all of their recommendations on the treatment of ARDS. Probably the major differences between the paediatric recommendations and the adults were that there's three of them really. One was the use of oscillation, which they didn't discount, and they said it may have some use. The second one was, Simon will know if he's here. The second one was the PEEP, the amount of PEEP that you use is much less than what the adults recommend for the same FiO2. And then the third one was the prone position. They weren't as firm on the prone position as being a good thing as the adult recommendations were. But the rest of it's pretty much the same, you know, like watch your fluid balance, feed the patient properly, limit your tidal volume, paralyse them if you need to, and that's about it. Yeah, and you know the transfusion trigger was the same as the adults, which is 70, which I always find it difficult to deal with when we group paediatrics as, you know, from neonates to 14-year-olds, and a 14-year-old, sure, your transfusion trigger might be 70, but for a neonate or a small baby that's used to having a hemoglobin of 160 or 170, I'm not quite sure that's the right number to do. But we do try and limit transfusion. Tracheostomy, again, like we're probably catching up a little bit with the adults. We used to very rarely do tracheostomies, and it was, you know, that would be after 3 or 4 weeks of invasive ventilation. Now we're tending to do tracheostomies earlier, and some of our bigger kids, like 12, 13, 14-year-olds, we do PERT ones. We probably do one of those a year. And in the smaller kids, we push to get a tracheostomy earlier rather than later, and for all of the reasons that it's a good thing in adults. You know, you cut the sedation, you can get them up and about, you can take them on and off, the weaning becomes much easier. And, you know, we have good ENT surgeons who are able to do it in a safe way, so it's not a big deal for us. We are, and I think it's a good thing that we're going towards more tracheostomies. Surfactant, that guy Doug Wilson, he was big on that. They did, you know, big trials. Well, they tried to do big trials of it, but it's prohibitively expensive. And again, it's one of those things that may change the compliance of the lung and make it easier to ventilate, and may give some transient increase in saturation, but in the long term it makes no difference to your outcome, and it costs a fortune. You know, it's expensive for a neonate. You give it to a kid who weighs 40 kilos, it's way expensive. So what is the next big thing? Well, I reckon the next big thing will be that. If we could somehow get a decent negative pressure ventilator, then that would be ideal. And not only for our, you know, dodgy cardiac patients, but in general. The problem is that we can't, you know. I haven't used one for ages, but when I was in Melbourne a long time ago, they had one there which just sort of, you know, had different size vests, but you could never get it to seal properly, and it never worked particularly well. I suppose I'm not sure if people are trying to develop that technology, but, you know, a decent negative pressure ventilator would be a very good thing to have. Probably at the newer modes of ventilation, the two things that stand out, that are being pushed commercially, are the proportional assist and the NAVA, which are, you know, the servo, or whatever they're called now, whoever makes them. But, you know, the NAVA, the triggering of the ventilator by the electrical activity of the diaphragm, when that technology first came out, it was mainly used, experimentally it was used in neonates, because neonates and small kids, our problem with ventilating them in any sort of spontaneous mode, as you know, is that we can't get them to trigger properly. We can't get the ventilator to cycle. So a triggering system that didn't, having the triggering system change from pressure to flow, and then putting the flow sensor right at the Y piece, was a really good thing for us in small kids, because it made the ventilator much more sensitive to patient effort to breathe. The problem still is that if there's a leak around the tube, or a patient is making very weak or can only generate very small flows, the ventilator still won't trigger. If you turn the trigger right down or make it very sensitive, it self-triggers all the time. So having something that triggered off the electrical activity off the diaphragm would be perfect. You know, there'd be no delay. As soon as it sensed that the diaphragm was starting to contract, it would initiate flow. It would terminate flow as the electrical signal dropped, and it would give support based on how big the electrical activity was. So whatever the effort you made, you got more support. And the system, as it's been experimented on and got better, it is now, you know, it's commercially viable. I mean, they sell it on their ventilator. We haven't used it. I've been to other hospitals where it has been used, and a lot of people rave about it. They say it's fantastic, but I don't know. You know, like, they're all at risk of this. We all go, you know, being the cynical person that I am, you look back on all the adult trials of weaning ventilation and getting patients spontaneously breathing. I mean, put them on a T-piece and let them breathe for 30 minutes, and if they look all right, pull the tube out. And that, you know, like, there's lots of papers that show that all of these, like pressure support and other modes of respiratory support for the spontaneously ventilating patient, delay extubation. Because, you know, we have patients on pressure support for days and we turn it from 10 to 8 to 6 or whatever. You know, like, whereas they probably, if they're good enough to breathe on a T-piece, they should just get the tube pulled out. But the proportional assist, what that does is it gives you assistance in relation to the amount of effort that you're making to breathe. And the problem with that originally was that if it couldn't measure what the resistance and compliance of the system was, then it didn't know how much support to give you. So the fancy software on some of the new ventilators enables the ventilator to be constantly measuring or getting some estimate of airway resistance and lung compliance and adjusting the amount of support that it gives. And you can set it to give you a set tidal volume, so if you make more effort or less effort, you'll get the same tidal volume because you'll get a variable amount of assistance. The problem is it's a spontaneously breathing mode, so it's no good if you paralyse someone. It doesn't, you know, it's not for that. It's a sort of weaning pressure support mode, like a volume guarantee neonatal mode, where it varies the amount of support depending on the effort. And they call it that. And the PAV plus is the one where it will measure or intermittently measure compliance resistance and adjust the amount of support based on those measurements. And then there's adaptive support ventilation, which again, you know, like, it gives you support based on the effort of breathing that you make, which is probably not, I don't know if it's a good thing or a bad thing, but it again, it's not been shown in any trial to make any difference to your ability to get off the ventilator or the speed of weaning. Okay, so you make a little effort. It can set the tidal volume, so it'll give you the same tidal volume. It'll just give you a different level of assistance depending on how much effort you're making to breathe. And then the neurally adjusted ventilator assist, as I said, measures the electrical activity of the diaphragm. It triggers off that, so there's no delay. When you start to breathe in, the ventilator will start giving you flow. You don't set it to give you a certain amount of flow or pressure. You just set it to give you a number, which I don't know how that works. But it gives you more support if you make more effort to breathe. So if the signal's higher, if the electrical activity's increased, then it gives you more support. And you can see there, can you see that clearly on the slide? How, you know, if you're pressure triggering or flow triggering, no matter how sensitive your trigger is, there'll always be a delay before you initiate breathing in and before the ventilator gives you flow or pressure, gives you flow. So if you can trigger it electrically, as soon as the diaphragm starts to contract, it starts giving you support, and then it cycles off either on flow or on when the electrical activity dies down to a certain point, it'll cycle to expiration. So like this, the triggering on and the triggering off are neurally based. They're not based on flow or pressure. It does have a backup so like if it doesn't trigger on the, if the signal's not good and it can't trigger on that, it will trigger on flow. So like it'll flow trigger if it doesn't trigger on that, and it'll flow trigger out as well, so it doesn't like keep making you breathe in if it loses the signal halfway through. And that's what it looks like. I mean, the catheters are really expensive. Well, they're a couple $100 each, and you've got to place them just at the right point so you get a good signal from the diaphragm. Once you get that signal, and it's got 4 electrodes, the catheters come in different sizes and lengths, so you can stick it in a neonate or you can stick it in a big adult, get it in the right place, hook it up, and then you're away. And as you can see there, that's the electrical signal at the bottom, so it cycles on when it first detects it, gives you the amount of support related to the height of the signal, and then it cycles off when the signal drops to a certain percentage of what the peak signal was. Fractal ventilation, again, like when we breathe, we don't breathe the same all the time. You know, like it's the old sigh on those old Bennett ventilators that you used to do. Or it's not only that, it's like we vary our tidal volume as well as doing the odd big sigh. We don't breathe at the same tidal volume every time. So some ventilators are getting the ability to vary your tidal volume, to give you a set minute volume, but give you slightly different tidal volumes with each breath. And the theory is that will allow sort of recruitment, and it won't just, you know, give you the same tidal volume, so you're stretching the same units all the time to give a smaller one, a bigger one. But again, no one's been able to show in any sort of reasonable experiment that it makes any difference to your outcome. I'll just show you this. We were all taught, I mean, as anaesthetists, you know, the narrowest bit of the paediatric airway was where? It was the subglottis. It wasn't the vocal cords, it was subglottis. And that's not true. The narrowest point of the paediatric airway is like the adult airway, it's your vocal cords. Okay? The reason that you get the subglottic problems is the cricoid is not a ring. I mean, it's a complete ring of cartilage, but it is not circular. It's elliptical. So if you put a round tube in an elliptical hole, to make a decent seal, it's got to be quite firm against each side of the trachea at that point. And that's why you get damage in that area. And so in the old days, we used to, you know, put a tube in and have a leak. And that was fine, except that now we're talking about having to trigger the ventilator and trying to save flows when we're doing anaesthesia by, you know, saving gas. We don't want a leak. We want to have a seal that is sealing the airway but not causing damage to the mucosa. And in the past we've either stuck a big tube down or we've put a cuff tube down, but the cuffs on the tubes that we've used, they've been totally inappropriate for what we do, because originally they just scaled down adult-sized tubes. The cuff's too long, it's too coarse, so like to get a seal you still have creases in the material and you need quite a lot of pressure, even though it's supposed to be a high volume, low pressure cuff. Because it has a Murphy eye, the cuff's a long way back from the tip. So when you have the tip in the right place in the middle of the trachea, the top of the cuff is almost bulging out through the vocal cords. And fortunately for us, and for the people who make these tubes, because they make a fortune out of them, they've developed a microcuff tube. Okay, and it sounds sexy, but it is a good thing. It has no Murphy eye, so it has a cuff which is very near the tip of the tube. It has a cuff which is made of very soft plastic, polyvinyl, and it has the cuff is rolled over on itself, so the tube can move in and out, and the cuff stays still. It's rolled. Sorry, it's rolled over itself like that, so the tube can go in and out. Cuff stays still. And they're expensive. They cost, I don't know, $12 versus $2 for a normal tube. In our hospital, we were annoyed in the PICU because the anaesthetic department actually got them approved for use before we did. And their argument was that, you know, one, it was the trigger of the ventilator, and two, it actually saved money by saving on the amount of gas that you used. And it may well be true. Yeah. So there's the one, well, there's two possible downsides of them. One is that, like any piece of equipment, if you don't use it correctly, then you can have trouble. you can overinflate that cuff like you can overinflate the cuff on any tube, and then cause subglottic edema or cause swelling of the airway where the tube's been, where the cuff's been. So monitor the pressure in the cuff like anything else. The other thing is the bevel. It has no Murphy eye and a flattish bevel, so if you poke it in the trachea to the carina, the tube itself can block on the carina. So you see some people, they intubate the patient, push the tube in, they pushed it in too far, they can't bag the patient. All you've got to do is withdraw the tube a centimetre or withdraw it off the carina, and then suddenly you can ventilate them again. So there's a couple of sort of things that are different to using a normal tube. But like we'd use that tube, what do you reckon, Brian? 80% of the time now? I think in anaesthesia it would be the same. Most people would use that tube and not an uncuffed tube and not an old cuffed tube. But it's not approved for use in neonates, and I don't know why they did the study, but they did. They looked at the incidence of stridor in neonates using the tube. They probably oversized the tube, so they used one that was too big, and they used it in neonates where they probably shouldn't have used it, and they did find that there was an increased incidence of post-extubation stridor compared to a normal tube. But it's small numbers. It was comparing patients who are having an anaesthetic procedure, got a cuff tube, versus patients who were in a NICU and didn't get a cuff tube. So I don't know what to make of that. Some people think that your incidence of post-extubation stridor has gone up with it. I'm not sure if it has or not. Another thing I mentioned is sedation. It's a big thing in paediatric anaesthesia, and all of the sort of neuronal apoptosis exposure to these drugs when you're a neonate can have long-term effects on your development, and there's a huge argument about whether it can or not, and what drugs do it and what drugs don't, what stage you're exposed to them, what dose you need, whether it's a dose thing, whether it's a single dose or multiple exposures. But I think most, smart trots, an American thing, who are monitoring it and putting out statement, their latest statement would say that, we should probably avoid all sorts of elective procedures in neonates. It doesn't say up to what age, but some people would say up to 2 or 3 years old. But there's probably equal evidence that says, you can have anaesthetics and nothing happens to you. There's a big Danish thing, they followed up 12,000 kids till they were 14 or something, and it showed it made no difference. It's really a confused thing, but we do, we use a lot of sedative drugs in the ICU, and we use them for days and days and days and days, and I would worry that is a bad thing for your brain. The question is, well, what is the option? And I think, the option is to be like the adults. Try and have people less sedated, more awake, and moving around. But then you've got to worry about your tube and all that sort of thing. But I think, less sedation is obviously better. That's just some papers looking at that a sort of meta-analysis of a lot of studies which have showed bad things happening with anaesthetic drugs or exposure to benzodiazepines, and that goes up to about the age of 4 or 5. And then there's studies, as I said, looking at patients that show there's no difference. So sedation is a big deal for us. I think of becoming, all that delirium work that's come out of the adults, we're far more aware of those things happening with small kids than we used to be, and we're more sensible and we're more measured in how we use sedation in the ICU. And I'll just put a shout out for ECMO. That's a technology which has really improved in the last 10 years, and we are using more respiratory ECMO in paediatric patients than we ever did, and that's without having those double lumen tubes available at the moment. I think, in the adults have made it a far more used therapy in respiratory failure, and we're going to follow suit with that. You look at the amount of paediatric respiratory, you look at ECMO for neonates, cardiac is static or down, paediatric respiratory failure and ECMO is on the way up. Thank you very much.